72-year-old woman has 8 months of right knee pain and stiffness, worse on exertion and relieved by rest. She has hypertension and type 2 diabetes mellitus, managed with ramipril and metformin. She has an antalgic gait with limited knee extension and flexion due to pain, joint swelling and palpable joint crepitus on passive movement. The figure demonstrates an X-ray of the right knee. Which is the most likely diagnosis? A. Gout, B. Osteoarthritis, C. Osteonecrosis, D. Osteoporosis, or E. Rheumatoid arthritis. Now just pause the video here for about 30 seconds and have a think about the correct answer. So the correct answer in this case is B, osteoarthritis, and we'll go through why in the following slides. Osteoarthritis describes a degradation of the articular cartilage in a joint, resulting from aberrant chondrocyte metabolism, bone remodeling, subchondral sclerosis and cyst formation, with inflammation and periarticular muscle and ligament weakness, which produces symptoms. There are a range of risk factors, including systemic factors such as age, family history, female sex, obesity, and the postmenopausal status, and local mechanical factors, including joint malalignment, a history of joint trauma, periarticular muscle weakness, and structural joint abnormalities, which can all predispose to osteoarthritis development. Symptoms of osteoarthritis include pain, which is typically better in the morning after rest and progressive throughout the day, worse with significant exertion. The joint may give way or lock. There may be associated bony deformities of the affected joint. There is typically stiffness with a reduced range of motion relating to both stiffness and pain on joint mobility. There may be palpable joint crepitus on passive movement while examining the joint. The joint may be tender to palpation. There may be associated malalignment, particularly in those with a history of trauma. There may be associated joint effusion, and if the hips or knees are affected, the gait may be antalgic. While osteoarthritis remains a clinical diagnosis, X-rays can be performed for correlation with clinical features to help confirm this. The X-ray features of osteoarthritis include loss, with L standing for loss of joint space, O standing for osteophytes, S for subchondral sclerosis, and S for subchondral cysts. And helpfully, the clinical features of osteoarthritis are similar no matter what joint is affected. And here we can see the thumb CMCJ joint affected by osteoarthritic changes, and we can see a loss of the joint space and subchondral sclerosis. The management of osteoarthritis is with a conservative approach in the first line, with rest and regular analgesia. NSAIDs can be particularly affected, and if taken regularly should always be combined with a PPI, and regular paracetamol is advised. Opiates are avoided due to limited clinical effectiveness and associated side effect profile and concerns retolerance. Physiotherapy is a cornerstone of treatment, and modification of any risk factors such as weight loss and a lack of weight-bearing exercise should be modified. If there is failure of conservative measures, intra-articular corticosteroid injection can be considered, and in failure of this, a joint arthroplasty can be performed, although this is typically last line due to the invasive nature. This slide provides an overview of the NICE guidelines for the management of osteoarthritis. They highlight how paracetamol and topical NSAIDs are effective analgesic measures, and in failure of these, other treatments such as oral NSAIDs, capsaicin cream, which is the chili derivative, intra-articular CSIs, and opioids can be considered, although opioids are typically avoided. Local heat and cold applications can be considered, and other factors that may be helpful include joint supports and braces, shock-absorbing shoes or inner soles, transcutaneous electrical nerve stimulation packs, and manual therapy, including manipulation and stretching. The cornerstone of management is education, advice, and access to information, strengthening exercise and aerobic fitness training, and weight loss if overweight or obese. Joint arthroplasty can be considered as a last-line measure if failure of all conservative measures that have already been trialled. Going back to our question stem, we can see that the features in this stem in keeping with the diagnosis of osteoarthritis include a long history of knee pain and stiffness, which is worse on exertion and relieved by rest. There are features in the question stem such as type 2 diabetes, which hint at an overweight or obese patient. Clinical features in keeping with this diagnosis include gait antalgia, limited knee extension and flexion due to pain, joint swelling and palpable crepitus on passive movement. The X-ray findings are in keeping with the diagnosis of osteoarthritis, with a loss of the joint space, subchondral sclerosis and cysts and osteophyte formation.